As you see, four of us were preparing this presentation to be concise and up to date. Why do we ablate AF fibrillation? Because from the multi-center studies, it showed that reduction of AF burden improves quality of life in symptomatic patients, improves left ventricular ejection fraction, and reduce mortality in heart failure patients, and prevention of progression of AF in the young when you start ablation early. Which AF patient you should not ablate? This is a mother's advice. First attack of AF, you don't go and ablate the patient. You don't know how he is, when his second attack is coming. Long-standing persistent AF, more than 1 year, you are pressing your luck for recurrence. After you did 2 sessions or 3 sessions of AF ablation, stop doing this because recurrence is coming. If you have an old age patient, you are not in the States. My aunt underwent AF ablation in America, and she is 83 years old. But here, I don't do ablations for patients above 75 years of age. Very obese patients are troublesome in anesthesia and in the results, and not more than 120 kilograms. This is my maximum. AF as end-stage heart failure, no touch. This patient is going to die on table. AF with hugely dilated right atrium or left atrium, also this means bad results. I will show you the studies. AF with rheumatic heart disease patient, like what Dr. Mohammed from Jordan did, this is, for me, this is obsolete, even if she is a young woman. AF with restrictive cardiomyopathy, don't touch. Annoying patient, annoying family, stay away from them because they will not accept complications, they will not accept recurrence. And the second ablation you do, you'll pay it out of your pocket. When to ablate? Paroxysmal, persistent. As you can see here, ablation of paroxysmal AF is associated with less recurrence rates. So if you go and ablate early, this means you will get good result and less recurrence. The East AFNet study showed that early rhythm control therapy was associated with a lower risk of adverse cardiovascular events than usual care with patients with early atrial fibrillation and cardiovascular conditions. What to ablate? What is your strategy for ablation? PVI, other lesions? Let's see. Comel triangle, and I like these slides because this is the first time I hear about Comel other than the Comel pathway. That was early in the 60s. He said there are 3 important components which are involved in AF pathogenesis: the trigger, the substrate, and the modulating factors. So we start by PVI only, and this is the typical for any paroxysmal AFib patient, and additional lesions are not needed in this condition. However, in persistent atrial fibrillation patient, we do not stop with PVI. In Egypt, we do the patient once at a time for life, and any other recurrences is not accepted by our nation. So when you have a persistent AFib patient, do the PVI first. We do voltage map. We use multipolar catheter to make a very good activation voltage map of the left atrium, and we go and do box lesion, and we do lines in the posterior wall, of course, and if there is fractionated electrogram, we tackle it also. The additional lines which are necessary in the persistent cases, the roof line, the anterior line, the box lesion. Sometimes it was once, Rania and I, we went to the SVC because the patient was not coming back to sinus rhythm, and we did ablation in the SVC with the care of a phrenic nerve. Left atrial appendage was introduced, but with, at the risk of implanting a device, an occlusion device. Ganglionic plexi ablation is also an option. The CAFE, which are the complex fractionated electrical atriogram, there is in persistent AF, the box lesion, yes, the posterior wall. Here is the effect, the comparison of the effect of catheter ablation using pulmonary vein isolation with versus without persistent left atrial wall isolation or on atrial arrhythmia recurrence in patients with persistent atrial fibrillation. This is the CAPLA randomized clinical trial. In this randomized trial, they studied 338 patients with persistent AF, and they were randomized to PVI or PVI plus posterior wall. This empirical addition of posterior wall to PVI did not improve freedom from atrial arrhythmias compared with PVI alone, and this is Ranya's opinion. This is not my opinion. I am the mother, I'm the operator, and she is my assistant. In a subgroup analysis on patients with rapid posterior wall activity, addition of posterior wall improvement, posterior wall is associated with significant improvement in freedom from AF accompanied with PVI alone. And this is here how the posterior wall would look like with the rapid posterior wall activity compared with the slower posterior wall activity, and this encourages me always to ablate and make a box. When I see this fractionated electrogram, I make a blue tag so that we can go there and ablate it. Standalone pulmonary vein isolation versus pulmonary vein isolation with additional substrate modification as index ablation procedure was studied in persistent and long-standing persistent left atrial fibrillation. And this, in some studies like the Ulster Lost AF, showed no difference in outcome between PVI alone versus PVI, CAFE, and linear ablation. In the guidelines, if you find atrial flutter in association with atrial fibrillation, either documented on the ECG or during the procedure, you have to ablate it. As you can see, Yaranya for guidelines, the third one, they are saying that use of additional ablation lesions beyond PVI, low voltage, fragmented, electrogram, ectopic foci may be considered, but it is not established. This is me. Friends, but different opinion. What is your way out when you cannot ablate a patient because she has rheumatic heart, she has very fast atrial fibrillation, she is not medically controlled? Then we do AV node ablation and implant his bundle pacing, and this we did it in some patients. Those patients with rheumatic heart who are undergoing surgery for their mitral valve, they can undergo surgical ablation, and this we did at Dar Fuad Hospital with Dr. Gamal Sami, but actually the results are not satisfying to me. How to ablate? The ablation energy you listened this morning, we have radio frequency, cryo balloon, and in this comparison in the Fire and Ice study, they showed that no difference in the primary endpoint with any atrial arrhythmia recurrence or between the RF and the cryo, and that was encouraging. However, persistent AF, cryo, or RF were also compared in many studies, and they showed no difference. However, in persistent AF patient, cryo balloon showed similar efficacy and overall safety as compared to RF. Cryo balloon is associated with shorter duration, but remember the phrenic nerve and the fluoroscopy time. The advanced RF technology versus the second generation cryo balloon. This is what we mentioned this morning, and it showed that patients who underwent AF ablation using the Thermocool Smart Touch SF radiofrequency catheter versus the Arctic front balloon had lower cost and AF-related readmission. The new technology of pulsed field ablation, which Dr. Ahmed Taher showed us, and this was compared to RF versus cryo balloon, and the pulsed field ablation after 1 year follow-up showed freedom from atrial tachyarrhythmias recurrence in 85% with the pulsed field ablation versus 66% in cryo balloon and 73% in RF ablation. Comparing pulsed field ablation to very high power, short duration PVI, there were comparable arrhythmia-free survival in both techniques. PFA, pulsed field ablation versus cryo, and they showed that AF recurrence rate after PFA seems to be comparable to cryo balloon. There are other technologies which are not applicable. Vagal AF can be ablated by anatomical ablation of ganglionic plexi in the right atrium in 70% of patients who had vagally induced AF. What to do in case of recurrence? Recurrence here, we have, if you have a recurrent case, you have to recheck the veins. Recurrence of AF after initial ablation means pulmonary vein reconnection. Depending on the study and the patient, the rate of pulmonary vein reconnection is between 61 to 81%. Second, check non-PVI triggers. And this is difficult because they might come from the posterior wall, the roof, and there are some techniques to find these triggers. Actually, I'm not a believer. Sorry. Checking low voltage area, this is very practical because you can use multipolar catheters to check for areas of scars, and then you can tackle these areas and you hope that you can ablate the patient. Here we can see that the ablation strategy, there is not a definite strategy you can be used. Similar outcome for paroxysmal and persistent AF. Left area size is the major predictor of recurrence. The left atrial size. Individualized approach for atrial fibrillation should be tailored by history, by examination, by documentation, by measuring left atrium, by the economy of the country, by the availability of catheters which are not available since many months, and patients are postponed. We have waiting list of hundreds of patients, and thank you very much.